I have the pleasure of introducing our two speakers. Dr. Fallah. Dr. Fallah is a pediatric and adult neurosurgeon who practices at UCLA Mattel Children's Hospital and Ronald Reagan UCLA Medical Center in Westwood. Dr. Fallah is board certified in neurosurgery by the Royal College of Physicians and Surgeons and board certified by the American Board of Pediatric Neurological Surgery. Additionally, he holds the position of Associate Professor of Neurosurgery and Pediatrics at the David Geffen School of Medicine at UCLA. He serves on the Board of Directors of the Pediatric Epilepsy Surgery Alliance and formerly served on the Registry Advisory Board for the Alliance's Global Pediatric Epilepsy Surgery Registry. Dr. Stone. Dr. Stone is a co-director of the Epilepsy Center and Director of Epilepsy, Stereotactic, and Functional Neurosurgery at Boston Children's Hospital. He is also an Associate Professor of Neurosurgery at Harvard Medical School. His practice is focused mainly on functional disorders in children, including treatments for movement disorders, spasticity, and epilepsy, with a focus on advanced minimally invasive techniques such as MRI-guided laser ablation, deep brain stimulation, SEEG, and neuroendoscopy. Please welcome Dr. Fallah and Dr. Stone. Thank you.
Okay. Thank you so much, guys. It's great to be here. I don't know if I can, do I get to see my slides somehow, or how does this work? No, I remember I loaded it on yours. Oh. One moment, please. Technical difficulties. Yeah. Just imagine incredible slides. Not really, no. You have my slides? I have your slides. Okay. Well, while we're getting this set up, it's great to be here, and it's been awesome to see a lot of familiar faces, people tracking me down and saying hello. It's been really, really amazing. See some of the kids, which is super special. But Aria and I know each other very well, actually. We both trained when we were little kids back in the day as young fledgling neurosurgeons in the same program before we went our separate ways. But now both do a lot of epilepsy surgery, as many of you know. And we have the privilege of talking today about reoperation after seizures come back. And
stop loading. There's a problem with the...
Any minute now.
Yeah. Was it up? I don't see it.
The screen is blank.
Yeah, no, just the moment I plug this in, it turned blank. Oh, no. Yeah, it's my computer now.
Well, his computer wasn't working either, so I feel like there may be some kind of setting issue.
Yeah. Okay, so let's try this. Oh, here. Extended mirror displays. Extend desktop.
Really working it out. Okay.
Do you want to just talk about it without the
Yeah,
you
maybe
can
I'll talk about it without the
conversation.
slides appearing, because
Let me just
we're hoping today is a little more conversational. I mean, obviously we prepared some content, but I think many people will have questions that maybe can help guide discussion to some extent. Because this is a very important area and can be very challenging, obviously, for you to navigate as families and patients, and for us to navigate as clinicians, trying to figure out what the right thing is to do and trying to make sure we don't cause harm. Because by definition, when seizures come back, it's not usually a simple situation. Okay, so I can see my slides, which will help guide my talk, but until we get things up here. So the first thing I guess that's worth talking about what seizure recurrence is, when it happens, because that makes a big difference, obviously, and then of course why it happens, which is very important to try to figure out what we can do about it. And then the next thing really is to evaluate, and first for us, could there be a need for more surgery? Could surgery have a role still? Is there something that makes sense? And how we go about doing that. So the first point I wanted to make is that sometimes when someone has had epilepsy surgery and seizures quote unquote come back, you need to just step back and sort of first ask very basic questions like, are these actually seizures? Because many of you know that children can have a lot of different manifestations of their epilepsy and their condition, whatever that may be. And in some cases, they're not actually epileptic events that they're having, they're other things. So, you really just want to confirm what we're talking about here, make the diagnosis, and confirm with the necessary tests that we're actually talking about recurrent seizures. Early after surgery, you can have different things that happen literally just from irritation of the brain.
Do you want us to try that?
Yeah, we'll try to fix it while I'm talking. Where, you may see symptoms that look like seizures or look a bit different, and they are often just a result of sort of inflammation and swelling related to the surgery, and one has to be patient and give it time. So, not jumping to conclusions, again, is an important aspect of that.
Next slide.
I don't think it's presenting still.
Oh, yeah.
Yeah.
I just wasn't sure if you needed it next.
No, that's fine.
Okay.
I can make this up if necessary. Another point to make is that, some seizures after surgery may or may not be expected. And that's obviously on us to make sure that we communicate properly with you about what to expect after surgery. But some of our treatments are, by definition, not expected to fully eliminate seizures. So that's always an important point. And sometimes, there can be a communication breakdown where that point may not be adequately communicated.
I just want to make sure you're on.
Oh, yeah. The other thing is that the effect of surgery may be expected to take time. So with some of our treatments, we actually don't necessarily expect there to be no seizures right away. We expect seizure benefit to come in a delayed fashion, whether it's like deep brain stimulation or vagus nerve stimulations or kind of neuromodulation treatments. So that can also be a factor which can come into play when you have seizures after surgery. I guess we could try his computer again. It's weird. As soon as you plug it in, it just goes blank.
Yeah.
There can also be many causes. So I talked a little bit about early post-operative effects, things like inflammation, swelling, irritation of the brain. And in some cases, and I see this quite often, where a specific seizure focus is targeted, and we're very hopeful. Let's say we've isolated it somehow. We're very hopeful. We think we got it. And then right afterwards, we're seeing some seizures. And I always explain that, there is this phenomenon where we've targeted kind of where the spark starts, but the seizure, of course, spreads throughout the brain, in some cases all over the brain. And as it spreads and hits different parts of the brain that can produce symptoms, you become aware of it. If you've just sort of operated on an area and there's a lot of inflammation and irritation in that area, it's very possible that you're going to trigger some events that are going to spread the same way. And until all that settles down, you actually will see seizures that can look almost identical to what was happening before. Also, sometimes there can be significant fluctuations in medication levels around the time of surgery. It's very difficult. Some of the meds, as you know, cannot be given not by mouth or not through the GI tract. So we do our best to cover things during surgery, but it's a stress on the body, and so for a while it can actually take some time for that to settle out after surgery, and one may see seizures in that context. Maybe there's an acute stress going on, an acute illness, some kind of metabolic imbalance or something. You know, a lot of times when surgery is, in quotation, successful, you may increase someone's threshold to seize enough that they generally don't seize in everyday life, but if stressed, you know, significantly enough, some of those seizures will come back. So, you know, we always need to, again, just rewind and say what's going on with the patient as a whole, and all aspects. And then, of course, finally, is there residual or new seizure-generating tissue in the patient? This could be because some tissue was left behind. It could be because there's evolution of the underlying condition. For example, a neuroinflammatory disorder may be still progressing and involving more parts of the brain, and that will progress over time and start to produce seizures again. Another important point that you would see if you could see my slides is that the difference between early and late surgery seizures is important to distinguish, because you know, a lot of these kind of reversible effects I'm talking about might be more expected to be at play with early recurrence of seizures. There's no sharp line separating these two areas, but you know, generally, if you have seizures within, say, days to a small number of months at surgery, there's a greater possibility that that's somehow related to a transient effect of the operation or the experience of going through it. Many possible causes that can resolve over time or be addressed medically in that situation. And then the contrast, of course, is a late recurrence, which is probably what interests most of you, and that is, you know, typically kind of in the months to years time frame where, again, although there are many possible causes that could still potentially be addressed without surgery, this is more likely to represent, you know, residual seizure-generating tissue that could potentially be amenable to more surgery. So when we evaluate the need for reoperation, you know, I really think it's important to really start at the beginning again. So we talked about confirming that these are actually seizures to begin with is important. Making sure that medical management is optimized just like back at the beginning, and correct any reversible potential factors that may be contributing to this. Then, of course, as painful as it is, it's important to at least repeat some, if not look at the whole comprehensive pre-surgical epilepsy evaluation that we do from the get-go. It's got to be multidisciplinary. You want a very careful evaluation of the technical results of surgery. So are seizures back because, you know, I said I disconnected the frontal lobe, and when I look back at the scan, it turns out I didn't actually completely disconnect it. So, you know, very careful evaluation of what the intended surgery was, what happened, did you achieve the original goals? Is this simply that you never actually completed the first surgical technical result that was intended? And then, of course, has things changed? You know, maybe you did do the right thing. Maybe everything was appropriate, but as I talked about, the condition has evolved. There's a new seizure focus somewhere else. The data that we had previously is no longer fully applicable. You know, should you really evaluate that again?
Goes through, but it's all back. So we're gonna go with this.
I think we've been sabotaged by the previous group. I think that's what's going on. So I had a very busy slide here, and the point of it was to just underscore this comprehensive evaluation. So listing things like going back to the basic clinical history, video EEG capture, good quality epilepsy MR imaging, neuropsychology testing, social work evaluation, what's going on in the lives of the patient and the family, and reviewing what additional tests could help us. Oh, here we go. Fantastic. Okay. That is the slide we're on. As you can see, too much information is what I titled it as.
Just careful of the cord for right now.
Okay, yeah, I'll be very careful of that cord. Okay, thank you so much.
Let me see that.
Yep. So looking at all these things, and without going through them all in detail, because that's not the point, okay. making sure that we fully understand everything as well as we possibly can, just like we tried to do the first time. And really, I just underscored that, again, the pillars of this really is this first box in that big diagram, which is, a good solid history, what's going on, what does the imaging show, how is the patient doing, how are they doing psychologically, so doing all of these things again to really make sure that we understand the basics. And I put down here, trust but verify. This is something I feel like I say 8 times a day in the hospital, but I really live by this in terms of what we do, and that is, in other words, don't trust anything. Relook at everything again, because you never know for sure. And I've learned that from many of my families as well, that they said, are you sure about this? Because this doesn't make sense to me, and they're often right. And then really we go back to considering, is there an opportunity for additional resection, laser ablation, disconnection? Like I said, were the technical goals of the first surgery achieved? So do you need to rethink, like, no, we never actually got to that? And then in some cases, if there is not an additional resection, ablation, disconnection option, is there another appropriate treatment such as neuromodulation to consider? So my colleague, Dr. Fallah, is going to get into more details about all those areas. So again, sorry about the technical difficulties, but again, we're hoping after he finishes that we'll have chances to have lots of sort of interaction, which I think is probably why most people are here. So thank you. So you're going to try to...
Yeah, I'll load it up. Do you have any questions in the meantime? I can take a question while this is loading. No? Okay. So,
Can we get your presentation on this computer?
yeah, it actually is on this one now. So, just contextually, one of the reasons why this talk is actually really important is if you look at the long-term data, the bad news is that seizure recurrence is actually not that uncommon, especially with some of the etiologies. So, typically things that, etiologies that do really well, and by etiologies I mean cause of the epilepsy. So things like tumors, typically you treat it, it's gone, seizures are gone for life. But when we start looking at some of the conditions like cortical dysplasia, some of the more common things that we treat, unfortunately, if you look at the long-term data, seizure recurrence can happen up to about 50%. And unfortunately, a lot of the studies that we look at that are done typically have seizure outcomes at sort of 1 year out. So it's really, you got to make sure it stands the test of time. And I always say this to the families, this is unlike some of the other things we do in neurosurgery where like if we're treating a tumor, you can take it all out with a margin, and when you meet with the family, you say, look, I got it all out. It's all out, it's gone, you don't have to worry about it again. Unfortunately, with epilepsy, you don't really do that. You have to, you complete the task that you were you had to do, and then you really have to wait for that child or that family to come back and tell you a year later, a few years later, that there's not been any seizure. So it really needs to stand the test of time. And is it? Oh, it's on here. Okay. And while this is loading, I just want to break up. So the causes, Dr. Stone mentioned this, but the way I break it down is the 3 different causes of seizure recurrence. One is you're completely in the wrong area, which can happen. It's rare nowadays with the technology and the tools that we have, but you can completely be in the wrong region of the brain where the seizures are coming from. And typically you'll know from day 1 because the seizures will look the same, no change in the way they present, and you really have to reevaluate. And in those situations, pathology is very important because you want to know whether that was normal brain that was, hopefully not, but if that shows normal pathology, it tells you you're in the wrong place, typically. Or you could be in the right place, but you haven't removed enough, and that's what Dr. Stone was talking about when sort of maybe the edges of you need to go back in and maybe extend your resection or remove more. And the third cause is sometimes just a completely different area of the brain that's generating seizures. So conditions like tuberous sclerosis and some of these conditions where you fully do treat the cause of today's seizures, but there's another part of the brain that decides to have seizures later. So those are the 3 different causes. But it's very important that even when the seizures return, not to give up at that point, because there's quite a few kids that we can help with an additional workup, right? And we really need to reevaluate. First of all, we have to make sure that did we complete the goals of our operation, and just really take a step back, see where the seizures are coming from, and whether there's further surgeries that we can offer. And the reason why that's important is because almost every child that's being considered for resective surgery, we know that further medications aren't necessarily going to help. So we don't really want you to go back on the medical journey again. And I'd say up to about 50% of the time, an additional resection, depending on the specifics of the case, can result in seizure freedom. And obviously, seizure freedom is important, not just on its own, but the advantages in terms of quality of life, cognitive outcomes, decreasing further medication use. You do need to factor, sorry, you had a question? Yeah.
When you say was it successful, 6 months, a year, 18 months, it doesn't matter for
Yeah.
the type of surgery, the type of patient.
It does matter, and actually, unfortunately, we don't have great data, but it depends on the etiology. So typically, the further out you go without having a seizure, the less likely you're going to ever have another seizure. So there is this time, it's definitely, that's not my, that's the slides.
It's not your slide?
No, those are his slides. So the further out, so there's nothing magical about, the 1 year mark or the 2 year mark, but the further out you go. Now, typically, your super conservative epileptologist will want to wait at least 2 years before they say you're in the clear. And even that is, we've seen late failures. And your super aggressive ones, which the ones I work with that I actually like, will wait about 6 months. If you're seizure free, then they'll start weaning the meds. And on average, probably about a year, right? So, but again, there's no magical date that we say, look, you've passed this date, you're seizure free. It's just over time it becomes less and less likely. Now I do want to pay a little bit closer attention to hemispheric surgery because a lot of the families here have had hemispheric surgeries that are part of the Alliance. And specific to hemispherectomies, it's a complex operation. There's many steps, and there's many places where you can actually incompletely disconnect the hemisphere. So, and I've learned this over the years that there's a lot of humility, right, involved in doing this type of surgery. You want to be able to really critically assess and make sure you've done a complete disconnection. I do see kids frequently that have been told full hemispherectomy, it's done, there's nothing else to do, that we can help actually with an additional operation. And I'll get to that in a little bit. If you're considering additional surgery, and especially a hemispherectomy, you do need to think about the risks too, because sometimes it's that second surgery where you develop hydrocephalus. And hydrocephalus is abnormal fluid accumulation in the brain. So they can be consequential. Obviously, additional surgery also comes with the infection risk. Oh, my slides are up, I didn't realize. Okay. Potential for neurological deficits, right? So if your first surgery, we decided to spare the motor area or the sensory area of the brain, and now we have to go back and remove some of that, there may be the potential for neurological deficits. Also have to think about recovery time, the need for rehabilitation. What's at the bottom there is typically when we see hydrocephalus, that's fluid buildup in the brain. This is following anatomic hemispherectomy. But I also want to say that hydrocephalus does not necessarily equate to shunts. We can sometimes treat hydrocephalus using other techniques like endoscopy, choroid plexus cauterization. Now, sometimes we do need to use shunts, but it doesn't automatically mean your child now needs a shunt. In terms of reoperation techniques, obviously we repeat major portions, if not all, of the pre-surgical workup. Sometimes we need to do a phase 2 evaluation. What we mean by phase 2 is placing electrodes in and around the brain to further identify the zone of seizure onset zone. And that can be very helpful as well. Typically in a reoperation setting, we're looking more towards SEEG. SEEG is a minimally invasive technique where electrodes are placed through the scalp inside the brain, and it doesn't require a large operation. And in those situations where you've had a prior surgery, it doesn't matter where you have surgery in the past, but the body always likes to form scar tissue. So whether it's the brain or the hip or the knee, anytime you go a second time to do an operation, there's scar tissue. And with a craniotomy, there can be quite a bit of scar tissue. So the SEEG approach typically allows you not to deal with all that scar tissue. Now, depending on what's left over, right, maybe there's a small area where you need to treat, and that can be done using laser ablation. The way I would describe laser ablation is that it's minimally invasive, but not super accurate in terms of being able to tailor the amount of tissue that you're ablating. So typically it's a small skin incision, we place a fiber into a specific area of the brain, and then we use heat energy to sort of cook that tissue. And unfortunately, you can't really guide where the heat goes. You're sort of just making a lesion in the brain. A lesion is a very general term we use for essentially an abnormality. You're causing tissue damage in that region. And this has been tried for hemispheric surgery failures. There's, I know a group out of Texas published their experience with doing this. It's somewhat effective, but there are limitations for what you can do with laser ablation. Repeat resection, so especially for hemispherectomy. So one of the things I wanted to discuss is if the hemispherectomy fails, sometimes it's very obvious on the postoperative MRI where the incomplete disconnection was, and sometimes you can target that specific area or go back and do a functional hemispherectomy. My approach, our approach at UCLA has been if it ever fails, we go back and do an anatomic. An anatomic hemispherectomy is the most definitive way, obviously, to remove a hemisphere, right? There's literally no tissue left on that side. So that by definition tells you if there are seizures that persist beyond that, then it must be coming from the other side, right? And the other reason why I like to do an anatomic in those situations is because when you, especially within the hemispheric surgery community, you will hear of kids who've had 2, 3, 4, even up to 5 surgeries to disconnect that same hemisphere. So, and at that point, by the time you've had 2, 3 or more surgeries, those kids almost invariably will have a shunt. So typically, we start with functional, and if we ever have to go back, do an anatomic. Now, if there's a very so different hospitals have different approaches. I do want to mention neurostimulation. It was briefly mentioned before. Vagus nerve stimulation can be a good option if there's not a curative, let's say it's the other side of the brain, or it's in a part of the brain where you cannot or you don't want to remove or disconnect. Vagus nerve stimulation is on label for use in children 4 years of age and older, so we do use that off label sometimes in younger kids. The other two options, DBS and RNS, are also off-label, but they're increasingly being used in kids who have a type of epilepsy that cannot be cured with a resection. And these are good options, and they can sometimes give you a dramatic decrease in the amount of seizures. I do want to take some time just to talk specifically about hemispheric surgeries. So when is a redo hemispherectomy considered? These are typically kids that have failed the initial surgery. I'm not talking about the first week where you can have seizures, but typically after the first month, if you're continuing to have seizures, especially if they look similar, and you do a workup and you think that there's still no reason or there's no clear evidence that the seizures are coming from the other side. EEG and MRI are very difficult to interpret following a hemispherectomy. So the number one advice about EEGs post-hemispherectomy is don't do them. You don't want to see, what's going on. And the main reason why is you're still going to see abnormalities, you're still going to see seizures a lot of times because the tissue's still there, but it just may not be connected, right? So EEGs are not perfect. MRIs are not perfect. So, and I've even we've treated kids where the MRI looks like a complete disconnection, and you go in and you do an anatomic, and those kids can become seizure-free about half the time. And the reason why is that the resolution is not good enough. It's not possible to tell what is scar tissue, residual connection versus scar tissue. So you really, and the way I approach it is, unless you're confident that the seizures are coming from the other side, there is very little downside to going back in, re-exploring, and perhaps doing an anatomic, because you've already paid the price of a hemispheric surgery when you've almost, if not all, completely disconnected that hemisphere, but maybe you don't have the full benefit of it. So, so this is really important to really, and especially, one of the things we look at is the manifestation of the seizure. If the seizure is still manifesting on the side of the body that corresponds to that side of the brain, so keep in mind, left brain controls the right side, right brain controls the left side, you want to have a very low threshold for considering that the seizures may still be coming from that side. And here, so at the bottom, so again, laser ablation, whether you do a repeat functional hemispherectomy or you go in and do an anatomical. And this is very surgeon dependent. I want to show you some examples here. So at the bottom left, you could see there's still a clear connection. This is the corpus callosum, the structure, this white structure at the center, and you can see it's clearly still connected. And this is to the right of that, this is a fancy imaging technique. It's called DTI, where you can actually see through this red area here that the left and right are still connected. So if you see that, these are usually pretty obvious cases where there's still a residual connection. You want to go in, disconnect. There are very important to get second opinions when it comes to this, because depending on where you're doing the surgery and who's doing the surgery, definitely seen examples where typically at a place where they don't do a lot of this surgery, if you look at this operation here, the insula is not even addressed, right? The insula is a part of the brain. It's right over here. Do you see my mouse cursor? You don't, okay. So, this is the insula, and you can see it's still clearly connected. So this part of the brain is disconnected. This is disconnected, but there's still a connection there. So, again, always good to get a second opinion, because sometimes, and you may be told by your surgeon that it's complete, there's nothing else to do, your child needs a VNS, but you want to really take a close look and sometimes get a second opinion. It can be very helpful. The most common place to have a connection still following hemispheric surgery is this frontal region of the brain. It's called the fronto-basal region. It's right over here. And this is the most common place that residual connections are left. It's particularly challenging, especially for a condition called hemimegalencephaly, because the brain can have an abnormal or atypical anatomical configuration. And this is an area where commonly, and usually it's one of the last cuts that we're doing after a very long operation, and very common to have some residual connections there. So that's a particular area that we want to take a closer look at. I do want to briefly mention this because let's say you've had an anatomical hemispherectomy and you still have seizures, and what do, right? So VNS is an option on label for kids, and that could be a good option. But the newer, and we're sort of just really starting to get into this, right? So there's been a few kids where we've recommended doing an RNS on the other side of the brain. An RNS is responsive neurostimulation. We call it a palliative epilepsy surgery technique. I don't like to use the word palliative, but palliative in this sense means it's not going to necessarily cure the seizures, but decrease the number of seizures. And there's been at least 4 kids who've had a RNS device placed on the more normal side of the brain. And still very early, 1 has benefited, 2 are sort of very short follow-up, so we can't really tell yet. and for one of them not turned on yet. So this is data that I was able to get through Monica, through some of the families that shared their experiences, not published. This is sort of very, it's sort of it's definitely a more innovative approach. But I put this on there just to let everyone know that even if the seizures come back, there's still more things we can do, right? And we're really pushing the envelope. We're sort of, we have this mentality now that we have all these tools and we got to get innovative, and sometimes there's a combination of VNS and RNS or DBS that works better. So we don't want to give up and say, there's nothing else to do. There are surgical options, and you definitely want to explore with your surgical team, and very helpful always to get second opinions if the seizures come back. In conclusion, just wanted to summarize 3 words: reevaluation if the seizures come back, second opinions, and think outside the box, because sometimes when we do that, that's when we can really take a situation, a child, and really be able to help them who may not have a lot of options otherwise. Thank you for your time. If there's any questions, Dr. Stone and I can happy to answer them. Yes, sir.
What's the downside of doing the anatomical hemispherically as opposed to the functional the first time?
Yeah, great question. So there are centers specifically for hemimegalencephaly, at least one center I can think of, that will choose to do anatomic hemispherectomy up front. Part of the reason why they do it is because kids, especially with that condition, can have a higher failure rate than others. So in the hemimegalencephaly community, there's quite a few kids who have anatomic. So one approach is to do an anatomic up front. The downside of doing an anatomic hemispherectomy up front is definitely more involved of a surgery. It's a longer operation, higher need for blood transfusion. There is data, most of it's historic, but there is data to say that there's a higher chance of requiring or developing hydrocephalus. So for the majority of centers, they will probably do a functional hemispherectomy up front and only reserve an anatomic hemispherectomy if it fails. I will say personally, from experience, that a functional hemispherectomy, the majority of times, is likely all the child needs. Yes?
Is there a time frame where we should be focusing on getting a second or third or whatever might be surgery in terms of their age? My child is puberty, started puberty,
Yeah.
and part of me is like, is this the wrong time? Because so much is going on. Should I wait, or is there benefits to doing it early?
Again, there's some epilepsy syndromes that are age dependent, but if it's a surgical epilepsy, so it's sort of, again, that requires an epileptologist who's knowledgeable and knows that this is a drug-resistant epilepsy. Personally, I don't find it ever beneficial to wait. The sooner the better. Yes?
I have a question for patients with hypothalamic
Yeah.
Do you know why, they'll get laser ablation and they'll be seizures for 8 years, and then the seizures come back. Do you know why that happens, and would you recommend another laser ablation, or could they do the stimulation?
Yeah, that's a very specific question. So just so everyone, so hypothalamic hamartoma is a pretty rare condition where there's a abnormality in the hypothalamus that generates seizures. It's very common to also have focal cortical dysplasia with hypothalamic hamartomas. So, and I've also seen children that have hypothalamic hamartomas, but their seizures are coming from elsewhere. So I don't want to get into too much detail without knowing details, but I will say a reevaluation, assessment of whether that ablation was complete. Typically, when we think of hypothalamic hamartomas, we want to disconnect it from the rest of the brain. You don't necessarily need to treat the whole thing, but you have to treat the connection with the brain. So a detailed evaluation there, and also making sure it is truly the hypothalamic hamartoma and not a cortical dysplasia that can be extremely subtle to find elsewhere. So, yes.
I have a daughter of 21 months old with epilepsy, which doesn't have the procedure yet.
Yeah.
But I want to clarify that she's doing good with the
Yeah.
development of the race. She has been seizure free since last September, almost a year, but she has had a seizure 2 days ago.
Mhm.
5 minutes seizure, still the same. And also from the last EEG, it showed right side epileptiform activity, but we don't know if it's the left, given like
Okay.
pushing the right, or if she has like epileptiform
Yeah.
activity from the right. So would you?
Let's have Dr. Stone, because if we've spoken, let's get a different.
We know each other too.
Oh, okay. So he's Dr. Okay. Yeah. 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 It's a controversial area of epilepsy surgery, and we may have mentioned that, but if the seizures are under control, it's if the seizures are ongoing, it's a slam. Like almost every place will say, do the surgery, right? Keep in mind that the EEG sometimes there's a phenomenon of false lateralization. So even if the abnormality is all on one side, there's certainly kids with hemimegalencephaly that can have abnormalities on both sides. But sometimes, especially if one hemisphere is much larger and pushed over to the other side, you may pick up abnormalities on the EEG on the other side, but may not necessarily be coming from there. And some of those kids, even with a hemispheric surgery, we can stop the seizures. But this is a gray area in epilepsy surgery, and there's actually, I'll say there's a movement towards even earlier surgeries. If you talk about hemimegalencephaly, so we looked at our experience since the 1980s, about 55 patients who we treated with hemimegalencephaly. Almost all of them had surgery at some point. I think there are some case reports maybe of some kids who've gone on later in life and still haven't had surgery, but it's extremely rare. It's typically a surgical condition. And one of the things we want to maximize is neuroplasticity and development. So one of the reasons why we may recommend surgery is if this surgery is required at some point, it's better to do it sooner than later. Because the older the child gets, it doesn't, then the recoverability may be less. But I say that knowing that there's a different practice pattern across the country, and there are some groups that would say, as long as we haven't failed 2 medications, we shouldn't even be talking about it. Yeah, it's a tough decision, because if things are good, it's easy not to do anything, but also at some point, if we need to do a hemispherectomy, then we got to take a step back and sort of recover some of those functions. But yeah, there's another question. Yeah.
My son had a functional left hemispherectomy at 8 when he was 2 months old, 7 now. If EEGs and MRIs are unhelpful in determining, where they're originating from, how do you figure out where the seizures are coming from? Like, it's
Yeah.
on that left side, or is it somewhere near on the right?
Yeah. So I can tell you some of the things we do. First of all, we look at semiology. So which side of the body is involved? So that can give us helpful information. We like to look at the pre-surgical MRI, because sometimes after surgery it's hard to see this, but some of our prior workup. Now, if we see a clear abnormality on the other side and we think that's the cause, if the EEG kind of correlates to that area, we may say, okay, this may be just coming from the other side. But at least I can talk to you about our experience at UCLA. We've kind of had an approach where if there's a recurrence of seizures, we're looking for reasons not to go back in and complete the hemisphere, as opposed to the other. And when we've taken that approach, I can tell you there are certainly kids that even on the MRI looks complete, EEG may not be super helpful, and about half those kids can become seizure-free. So we've sort of taken the opposite approach, unless we're absolutely sure it's coming from the other side. And again, the reason why is you've almost completely disconnected that hemisphere anyway. So you've basically paid the price of it. I don't know, what's your approach in that situation?
Yeah, I mean, I think you know, it's always hard to comment on specific cases, obviously, without looking at everything. But you know, I think we really look very closely at the current state of the brain, and you know, we really want very high resolution MR imaging, because you certainly, as we were saying before, really want to evaluate the technical success of the first surgery. And you know, I agree. I mean, these can be difficult surgeries. Some parts are very difficult to sort of be 100% sure, especially when you're not the one who did it. You know, and not to sound egotistical, but you know, I know, and I'll dictate in my own note like what I saw, and there are clear points in these operations where you can directly visualize and confirm, and somewhere maybe I couldn't quite see. So really evaluating with that detailed MRI to see if anything is still connected. And I certainly agree, this frontal basal area is an area we see and patients referred in that have had surgery, and you can see a little connection, and sometimes you treat it, and that actually does the trick. I would not, you know, discount these tests. I mean, I think that they're helpful. I agree they can be, you know, no test is perfect, but we would obviously look at everything to try to determine, and I think it's, you know, it's very important to keep an open mind and not accept that necessarily everything was completed as it should be. The flip side is, you know, there are cases where it was completed, and it's just, unfortunately, it's coming from the other side, and you know, you want to always be careful not to, you know, to some extent I agree. I mean, if you've already kind of disconnected a hemisphere, then some of the neurologic risks of going in and taking some out may not be there, but I wish I could stand here and tell you that there's no complications in any of our departments, even his, you know. So unfortunately, sometimes, you know, you have to be cautious, and if there is no evidence at all, and it's very convincing that it is the other side, you might want to stand down and sort of say, okay, I think we have a clear story here. But it is very difficult to tell sometimes, and when there's uncertainty, there are certain cases that you'll go in and just give it a shot.
So if it's somewhat obvious from watching them have a seizure that it's coming from the opposite side, medication or like you were talking about the RNS, is that what you would recommend after that point?
Yeah, I mean, certainly, so now we're in the, let's assume, and correct me if I'm wrong, but we're in a situation where we feel fairly confident that the seizures are still arising from the other side. So, you know, in that case, there's not a resection, sort of disconnection surgery option. So if we're in that mode, then, you know, 100% we want to evaluate the medical treatment and make sure that that's optimized first. Because now we're looking at surgeries that are aimed at potentially reducing the burden of seizures, but likely not eliminating it, you know, and we're looking at these neuromodulation things. So I think that RNS, or responsive neurostimulation, or NeuroPace is the device for those that don't know. That is the latest technology that's not very well studied in this situation, as evidenced by, you know, the 4 people that were dug up. But that is certainly an option. I'd say the conventional option would be vagus nerve stimulation, and some of our families will opt for that first because it is, depending on the age of their child, approved for that use. There's more experience with it. You don't have to put anything in the brain, so from a risk standpoint, you know, you're not touching the brain, so there is that advantage. And, you know, although I hate to stand here and say, like, and then there's more surgery, but, you know, if VNS doesn't work, you haven't burned bridges in terms of other options potentially moving forward. I have not personally treated a patient with deep brain stimulation in that scenario, which it is technically an option, though you are putting a probe, you know, into the brain through the good hemisphere. Very, very low risk, but say a 1% risk of a hemorrhage on the only remaining hemisphere that's providing function. It certainly can be risky for a therapy that is not expected to eliminate the seizures, you know. So I think that's kind of our general approach there. Yes?
For a patient who is maybe having a status
Yeah, I mean, so I guess the short answer is yes. I mean, obviously, we have patients that are very challenging, very rare seizures, but potentially significant seizures, and it is a difficult decision. I think one of the advantages of a pre-surgical workup is that it's probably not the right phrase for that workup. Pre-surgical implies like it's definitely surgical, but really it's an exploration, of options, and it also entails understanding the current state of the child. So that will involve a neuropsychology assessment, developmental assessment. How are they actually doing? Because some kids they're doing pretty well, but then when you really dig deep, you realize that there's a lot of other issues that it just helps you with more data. More data is always helpful. I always say we shouldn't be afraid of more data because understanding the situation and what are the options, you may have been told the only operation is to do a hemispherectomy or something. But there may be other options. Post hemispherectomy. I'm sorry. Yeah. Yeah. Well, that's mostly great. But I think, there's no harm in being informed, about what options are there. They may be rare seizures, but there can be a risk. I mean, there's a risk of sudden death with seizures. And sometimes we find this routinely, right, in our patients, for example, getting stereo EEG, where we're getting very sensitive recordings of the brain that although we, on the outside, recognize 2 seizures a year, it might actually be that there's more seizures happening that are not as obvious on the outside, and those can be having detrimental effects. So I certainly am not standing here like a snake oil salesman saying, yes, more surgery, but I do think that understanding as best we can the current state of the child's health and seizure control, and for you understanding what are the options. It is a moving field. If we're up here giving this talk in a year from now, that slide with 4 patients with RNS is probably going to be 20 patients, and maybe there's a case series published, and maybe we're seeing different results. And it's a moving target. So I think there's no harm in exploring and learning. Yes.
If we go and get a second opinion and we send information, our home hospital is Children's National. You actually performed our daughter's hemispherectomy a few years ago. We thought we saw something, and we sent the MRI to Dr. Bolton, the EEG that was very chaotic, not a lot of help, but I almost feel like we should have gone to Boston to do it with your MRI, your EEG. Do you like when it from your hospital?
Yeah, that's
your imaging, your
right. That's a great question. I would say that is one area where I wish we were more connected on, is our ability to share a lot of that information. It may be impossible for the neurologist to get the raw tracings for whatever reason. The software is different. Everywhere has their own sort of MRI secret sauce, that they're doing, and they may believe that's better. And so it is a challenging area for anyone to evaluate second opinions because of that. I think that the short answer is usually it's preferable to get that data locally, done the way that we have validated and we have experience making decisions on, and following outcomes on. It's not necessarily that someone else is not doing it as good. It's just, you're using what you have your own kind of sense for how to look at that data. But I know that's really difficult for families, and I would say, I think that I would be guided by whoever you're getting the opinion from. Show the data. Does this give you what you need? I mean, we get a lot of second opinions, and the imaging is fantastic, that we get from the outside. And somewhere we're like, I can't make a decision on this. We want to do a repeat scan anyways. If you can come here, we'll try to package it all in one trip and get it the way we like it. I don't know if that helped much, but yes. By the way, can I just pause for a second? Is there another session starting? Are we in trouble or no?
This isn't going over the speakers, but it's going into the video.
Okay, yep, sure. I just didn't want to throw anyone off. So yes, I'm
Okay,
sorry.
I squeeze in. I don't know if maybe you can hear me, but so generally speaking, kind of coming off of some of the questions that other people have asked, I've heard, not necessarily read too much about, how often is it a risk that if it isn't fully disconnected, that it can retrain the good side of the brain? Like, I've heard that mentioned, and I don't know if that's a real phenomenon or how significant it is, but as neurosurgeons, do you see that as a concern or something that should be considered?
So I'm just going to make sure I understand the question.
Yeah.
Are you saying that, like, is there a risk that that the quote-unquote good hemisphere becomes epileptic
Yes.
because of exposure?
Yes.
So I would say that we generally believe that, yes, that is a concern. We actually don't have, that concept we call kindling kind of in the neuro field. It seems to happen in certain areas of the brain, more likely like the temporal lobes. We don't actually have really solid evidence that it does happen, but we do believe it can happen, so it's a bit of a tricky area. We certainly have patients that, either by data or by history, they originally had very clearly focal seizures, and then it progressed to a more generalized kind of Lennox-Gastaut picture. Could there have been an opportunity to intervene when it was more focally and before it maybe influenced the brain, or was that biology going to kind of progress that way? And we just don't know for sure. So it's a concern. In the absence of knowing for sure, we err on the side of thinking it's better to get in sooner and try to prevent that. But we also don't have solid data that is a real thing that happens.
Thank you.
Great questions. Thank you so much, everybody.